Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today's podcast is entitled How to Get the Most Out of Your Appointments, Physician and Patient Perspectives with Dr. Greenberg and Kristen Smith. My name is Chrissy Dilger, and I will be moderating this podcast. The TMA is a nonprofit focused on support, education, and research of rare neuroimmune disorders. You can learn more about us on our website at myelitis.org. This podcast is being recorded and will be made available on the TMA website for download via iTunes. During the call, if you have any additional questions, you can send a message through the chat option available with GoToWebinar. We want to thank the sponsor of this month's podcast, Alexion. Alexion is a global biopharmaceutical company focused on serving patients with severe and rare disorders through the innovation, development, and commercialization of life-transforming therapeutic products. Their goal to deliver medical breakthroughs where none currently exist is driven by the knowledge that people's lives depend on their work. For today's podcast, we are pleased to be joined by Dr. Benjamin Greenberg and Kristen Smith. Dr. Benjamin Greenberg received his Bachelor of Arts degree from Johns Hopkins University and his master's degree in molecular microbiology and immunology from the Johns Hopkins School of Public Health in Baltimore, Maryland. He completed his residency in neurology at the Johns Hopkins Hospital and then joined the faculty within the Division of Neuroimmunology. In January of 2009, he was recruited to the faculty at the University of Texas Southwestern Medical Center, where he was named Deputy Director of the Multiple Sclerosis Program and Director of the new Transverse Myelitis and Neuromyelitis Optica Program. Dr. Greenberg is recognized internationally as an expert in rare autoimmune disorders of the central nervous system. His research interests are in both the diagnosis and treatment of transverse myelitis, neuromyelitis optica, encephalitis, multiple sclerosis, and infections of the nervous system. He currently serves as the director of the Neurosciences Clinical Research Center and is a Cain Danius Foundation Scholar. Kristen Smith began losing sensation in both legs on December 20th, 2012, and in a matter of a few hours, she was paralyzed from the chest down. 3 months after Kristen lost the ability to walk, she was diagnosed with transverse myelitis. Still requiring the use of her wheelchair, she was determined not to give up her dreams. Kristen has since completed her master's and PhD in atmospheric science at the University of Maryland and now works at the National Aeronautics and Space Administration in Florida. Welcome, and thank you both for joining us today.
Thanks. Glad to be here.
Yeah,
Thank you.
So for this podcast, if you two just wanted to go over some tips for success for an appointment and kind of elaborate on that.
Sure.
Yeah, so Kristen, do you want to begin? Give your thoughts?
Sure. I can just give a little bit based on my own experience, more so in the last 5 years since I've had TM and my visits with doctors, various doctor's appointments. Some of those things that I've found to be extremely helpful for myself is just to try to be a little more organized and to keep a list of any kind of medical things that are bothering me, whether it's a pain I'm experiencing or maybe I've had to see a different physician for something unrelated to the transverse myelitis, and just to keep a list of those things so I don't have to be thinking on the spot while I'm visiting my neurologist talking about my transverse myelitis. So I tend to keep a running list of things like that that are affecting me. And I also try to keep a list of any other kind of questions I might have for my physician, whether it's my neurologist, primary care, et cetera, things that are unrelated to the transverse myelitis, whether it's maybe some physical therapy that I'm getting or should be getting, or any kind of vitamins or supplements, any things along those lines that are questions that are bugging me in the back of my head that I'd really like to have answers on. One of the other things I find extremely helpful for me when I visit my physicians is to either bring a family member with me or to make sure that I bring a paper and pen to write down any notes, because I often find that I'm so deep in conversation and focused on the discussion that, 5, 10 minutes later, an hour later, I don't remember everything that we discussed. So it's helpful having either another person there with you or just to jot down some notes. And then the other big thing I have to say with having a successful appointment is if you're confused, don't be shy about asking questions. And that's something that I've had to learn slowly over time, because I didn't necessarily want the physician to think that I didn't understand what he was talking about and feel silly. But in retrospect, don't be afraid, just speak up. They're there for you. So feel free to ask them whatever to help put your mind at ease and to clarify any questions you may have.
Great, thanks.
Oh, go ahead.
No, go ahead.
So I was going to say those are all spectacular points, and I agree with all of them. The being organized and having another set of ears in the room, even beyond taking notes. It's amazing how many times multiple people will hear the same conversation and come away with slightly different versions of the same conversation, and that is usually a sign of, on the presentation side, maybe people weren't being as clear. And so having another set of ears in the room is incredibly helpful for the aftermath from the visit and really understanding. I would, as a backdrop, just put out a couple statements that are partly assumptions and partly fact, that really set the stage for the challenges people have in the healthcare system today, even when you're just behind closed doors with a healthcare provider. So the first assumption that I'm going to put out is that almost always the individuals who have gone into the profession of providing healthcare, whether it be a medical doctor or a physician assistant or nurse practitioner or nurse, that in general we got here because we want to help people. We are there rare individuals who were getting into a profession to build an empire or make money or start a business or all sorts of things? Sure, but far and away people chose these professions because we really want to be of service to our neighbors and to everybody in the community and people who need our help. So from a starting point, at some point your clinician picked this profession for altruistic or good reasons. The second aspect, which erodes our ability to do that perfectly, is time. Far and away, at least in my experience, the biggest predictor of actual success in a clinical encounter dealing with an issue and with perceived success, how people will rate the quality of the encounter, is very much driven by the amount of time that is spent in that encounter. If I have 4 hours to spend with one person, I can delve into things that are very important and in depth, and not only leave with good feelings about what we accomplished, but actually coming up with good plans that are well executed, well understood, and all questions are answered. The challenge is, in today's healthcare world, the amount of time we can spend per patient continues to go down. So when I did my training in an academic neurology office, we were allotted on our schedule 90 minutes to spend with a new patient, 45 minutes to spend with a follow-up. Fast forward to today, things nationwide have moved to 60 minutes and 30 minutes in a lot of academic centers. In some, it's 40 minutes and 20 minutes, and in others, it's even 30 minutes and 15 minutes. So in a follow-up visit with an individual, whether it's transverse myelitis or neuromyelitis optica, or any condition, Parkinson's or stroke, imagine trying to get everything that needs to get done in under 15 minutes. And that is the reality of the healthcare system as it's currently designed. And so the challenge for us, the clinicians and patients and families, is how do we get 30 to 60 minutes worth of meaningful conversation and exchange done in 15 minutes. And to some extent, it's like fitting a round peg in a square hole. The deck is stacked against us when we walk into the room. So this is where the notion of organization comes in, and recognizing that the moment you enter the room, there are forces at play that may interfere with your ability to get all the information you want out of that visit. And I'm happy for us to talk through kind of, and we will, what those strategies are, but I thought it would be worthwhile just to set the stage of those are at a baseline, even with the most well-intentioned, intelligent, well-versed clinician in the world, you are going to run up against the aspect of time. And it's something that I think most people have been perceiving over the last decade, that the amount of time being spent with you in clinics is noticeably declining.
Thanks for that clarification.
The depressing statement. Yeah.
Yeah, well, I think that that is a conversation right now that a lot of people are having because it's a real problem. But thanks for clarifying. So I guess that leads us into one of our questions. What if you aren't getting the feedback time or care that you think you deserve from a physician? Like, what would you recommend somebody do?
So there are lots of different versions, and Kristen, I'm very curious to hear kind of what your experiences have been over the years. But the part of analyzing the unfulfilling encounter is to try and understand why was it unfulfilling. And there are lots of reasons it could have been unfulfilling. It could be unfulfilling for time reasons. There just wasn't enough time spent. It could be unfulfilling for personality reasons. Sometimes patients and their clinicians just don't gel from an approach perspective. And it can be unfulfilling from a perceived knowledge gap situation, that the clinician just doesn't have the tools to provide the care. And then finally, it can be unfulfilling, at least in my estimation, from a sense of a lack of true investment on the part of the healthcare provider. Either they're not listening or they're not interested, or both, in what's going on, and people will leave a room feeling as though they haven't been heard. And I hear that quite a bit from my side of the table. Kristen, I don't know if this rings true with either of any of your experiences, or if you've talked to other patients, their experiences.
Yeah, I've seen both sides. The more negative side that I've seen, my experience with one physician was from the moment he came into the room until the time he left, he was just buried in his laptop, like taking notes. Didn't really interact with me that much at all, other than asking a question here or there. And I really didn't feel like I was getting too much out of the appointment, and was a little more discouraged, and was wondering why I was even there and what the point was of even returning for follow-up visits. And what I actually found over time is that if I came with my list of questions, it suddenly drew him out of his computer, and it became more of an interaction between the two of us. So while it was upsetting that it took that long for me to see that change, it was nice to see that, okay, there was something that maybe I could do to try to change that interaction a little. So in the end, this more negative experience turned into more of a positive one once I figured out what it was that I needed to kind of change to draw him away from the computer and to interact and look at me. So that was one side. And then the other side, I found that in those instances where I don't feel like I'm getting necessarily the care that I deserve from a particular physician, is that I can lean back on my other physicians, like a primary care or my neurologist, that are a little more familiar with what I'm going through with the transverse myelitis and understand maybe the urgency that I need to see somebody in a specialized field, and then they can give me a recommendation for somebody else that I might be able to see. So I've seen both sides of the table, and I see where I can kind of make the changes that I need to make sure that I'm getting the care that I deserve.
And so, the situation you describe in terms of a clinician buried in a computer screen is a pretty common one these days. I'll ask, not to put you on the spot, do you know or have a suspicion as to why clinicians are buried into the laptops? Has that ever been communicated? Because we haven't all of a sudden recruited a lot of antisocial personalities to medicine. It's not the
right.
The phenotype. Again, it's a systematic event. We are now required, in order to bill insurance from a compliance perspective, there is a long list of things that have to be documented in an electronic system in a specific way in order for insurance not to kick out that billing. And there's no time to do it except in the room with you. And so a lot of clinicians, or at least the way most practices are set up, so a lot of clinicians have been forced to bring the computer into the room. Some people bring scribes into the room to do this, but somehow in real time or the moment they leave the room with you, certain things have to be recorded. And so it creates, and it's all an aspect of time. If instead of seeing 20 patients in a day, we went down to 10, then there would be time in between each patient to document what we needed to, and we could sit across the table from you with no computer, nothing, and actually have a human interaction and a human conversation. But the infrastructure is being created to dramatically change the way that interaction occurs. And what you did, drawing your clinician back to being humanistic and having that eye contact and interaction and thoughtfulness is extremely important. And your strategy of using a list is a very good one. I will even add to that and make some suggestions for everyone listening of different strategies that can be adopted to break that cycle of a lack of interaction. And so the use of a list is a good one, and in addition to that, prioritizing. So if we go back to the notion that there's a limited amount of time, you may come in with issues related to work, issues related to pain, bladder function, walking issues, needs for documentation for FMLA. I mean, the list can go on and on and on. And the clock is ticking, so to say, as people get in. So whenever having that thought process before you show up of what's going on in your life, what would you like to address, and then rank ordering them. And acknowledging at the outset of a visit, I find this to be one of the most helpful things patients can do in this situation, is when they sit down, making a statement about the fact of, I'm cognizant of the fact we have limited time. It's a very powerful statement because it does two things. Number one is it shows a recognition of an external force that's going to dictate care. You are basically forgiving your practitioner ahead of time for the fact that they're not going to spend 2 hours with you, that you recognize the reality of things. Practitioners often will then take a step back and realize, that's not the important thing here. The important thing is to do care. And most practitioners will say, listen, we're going to take the time we need. And you can follow it with saying, well, I came prepared with a list and I have my priorities. Can I start with my top priority? Those two sentences, the recognition of a lack of time and then the stating of what your priority is, to your point, Kristen, the list, I find to be very powerful ways to draw clinicians out of their bubble and back to what they meant to do, what they originally intended when they put in their medical school application all those years ago to do, and that was to be of service. And those are some of the language strategies that can be used to engage clinicians. And I'll put one caveat, and Kristen, I don't know if this has ever happened to you, but I'll have some patients come with their list and they've set a priority. I'll give an example. They may say, Dr. Greenberg, my priority is fatigue. I'm very tired. And the number 2 on their list may be a bladder issue, and the number 3 on their list may be their walking. And when they tell me they're fatigued, I may start to ask questions and discover that it's actually the getting up at night multiple times to go to the bathroom and the fact that it takes 10 times as much energy to take every step. I may discover that the number 2 and 3 on their list is driving their fatigue. And I may say, listen, I know your priority is the fatigue, but I'm going to focus on your bladder because if I can get you sleeping through the night, you're going to be less fatigued. And so as you come with your priority list, you have to be prepared that after taking a history, your clinician may focus somewhere else because they're intertwined. And it becomes a give and take and a conversation as to why. And Kristen, I don't know if you've ever had the experience of coming with a list and your clinician saying, well, listen, we're going to focus on number 2 or number 3 or whatever the case may be. But usually there's a rhyme and reason to it.
Yeah.
Hey, Kristen, we're having trouble hearing you. I don't know if you can get into better cell reception.
Can you hear me?
Yes, that's
Now
better.
Yeah.
All right, perfect. So yeah, I found that the list definitely helped to drive the conversation with my physicians and what we focus on. And it's just been very helpful, at least for me in identifying what the main topic is that we focus on and where we go from there. And even just it helps beforehand too, just deciding what topics are more relevant to, say, my neurologist versus the primary care physician, so you're not wasting more of that precious time that you have with one physician focusing on topics that, could be addressed by somebody else. So
yes,
that I found to be helpful as well.
Yeah, no, that is a very good strategy. And when you are involved with multiple clinicians, it is very important to define roles on the team. So technically you're the quarterback, but if we take you out of the equation, amongst your various physicians, somebody needs to be in the lead. Sometimes it's a primary care physician, sometimes it's a neurologist, sometimes it's a physiatrist, sometimes it's an OB-GYN. The credentials don't matter, but somebody has to be tasked with keeping track of all the different recommendations being made and the treatment plans, to be on the lookout for things that don't make sense when combined. And it's important to articulate to your clinician, and the best example is pain. you see your fill in the blank, primary care physician, neurologist, or physiatrist, and one of your issues is pain, and they make a prescription. It is important to state, are you going to be my primary for managing this? As we make changes to this plan, am I doing this with you? And assuming they say yes, you do not want any other practitioner changing that regimen. So you want to make sure that somebody has clearly committed, has articulated the fact that they will be overseeing the management of whatever given issue we're dealing with. Because often we will start a process with a patient where we assume we're going to be making changes, and if other clinicians start changing things, we never get to follow through with our full plan. And so it's helpful to have the conversation of who's going to be calling the ball relative to each issue. And so, oh, go ahead.
No, go ahead if you have more to add.
Well, I was just going to say the other aspect, Kristen, of what you were describing was you were able to draw the clinician out of their computer screen. What would you have done if you couldn't? What if after your list they were still very myopically just focused on the screen when you came in?
I think for me, and I don't know if this is a more drastic approach, but if it had been several follow-up appointments where I was getting the same response or same behavior, that I would probably investigate another physician in that area that I might be able to go see instead, and to see if there was somebody else that I might be able to mesh with a little bit better. Other than that, I'm not really sure if I would be brave enough to actually say something to the physician about how I might be expecting more from the appointment, but felt like I wasn't getting it.
Yeah.
So, yeah.
Yeah. So let's kind of go through. Every I shouldn't say everyone. Lots of people are nervous about criticizing their physicians to their physician's face. Mm-hmm. It's a very intimidating thing to do. It's an intimidating thing to criticize anybody. To walk up and say, listen, listen, I think you're doing a bad job, and let me tell you why. That's just a hard thing to do in general. I think for a variety of reasons, it seems even harder when it's your healthcare provider that you're giving feedback to. And at its core is just human nature. Nobody likes receiving criticism or feedback. None of us do. We don't like hearing it from parents or significant others or children or customers or colleagues. But there's something even more intimate and personal in the healthcare setting. So part of this is going through how can feedback be given in such a way that it does not invoke defensiveness or anger. The goal of feedback is to get somebody to be introspective and not defensive. That's the entire goal. And often individuals who want to give feedback, whether it's to their physician or to their mechanic, it comes across with anger. Because often the situations that lead to a need for giving feedback are serious and personal and infuriating or upsetting. And so people will emotionally give the feedback with a tinge of anger. And people don't want to do that to their doctors. So one of the things I encourage people to do when approaching physicians or healthcare providers that they want to give feedback to but are afraid to is to use one of a variety of techniques for disarming the individual and making them not defensive. So one of the classic ones that gets taught is the sandwich technique. you start off with a sentence of positive reinforcement or appreciation for something done well. Dr. Greenberg, I really appreciate, the time, you take when listening to my issues. I know things aren't easy. I know there are a lot of pressures to get through, but you don't just come in and spend 30 seconds. You're sitting here and listening. I appreciate it. And then you transition to the criticism. I feel like either I'm not doing a great job of expressing what my concerns are, or there are other reasons that are interfering with our communication. I'm not sure what they are, but I don't feel like it's getting through. I think we're on two different wavelengths. And you end with something positive, which is, listen, I'm really committed. I want this to work out. I value your opinion and the training you've had. Can you give me some advice on better ways to express this? Which is very different than coming in and saying, you're not hearing me, I'm going to find another practice. And so finding the language to draw people in, to take a breath, and to be introspective, and to say, geez, my patient feels as though they're not being heard. That is the last thing I ever want to happen. Let's constructively go through ways to fix it. So trying to find ways to give that feedback in such a way that it doesn't make people defensive. In general, if you take physicians as a group of individuals in society, there's a fair amount of us that have egos, and we can definitely have some diva type qualities to how we go about things. And so the sandwich technique tends to work because there's a little bit of ego petting that goes on as you're giving the feedback. And it's just, I think, frankly, again, if it's your physician or your significant other, how you give feedback is critically important to, is that feedback going to be internalized and successfully change the situation? The analogy I use, and Kristen, I don't know if you think it's a fair one, but the analogy I use for the doctor-patient relationship is, it's like a baseball game where the physician's the batter and the patient is the pitcher. But in this baseball game, you're on the same team. You are pitching to your teammate, and so you want me to get a home run, and I want to get a home run. And so how you serve things up, if you're giving me curveballs and fastballs, or you're yelling at me as you throw the ball, the likelihood of me hitting a home run is significantly lower. So you want to be giving the positive reinforcement, which is silly. It should be the other way around. But you want to be giving me the positive reinforcement and throwing nice, slow, straight balls so I can hit a home run every time, because then we both win.
Mm-hmm. Yeah, and I agree that technique, I hadn't necessarily thought of it in that way, but that is definitely a good idea and a good approach, because for me, just in my experience, mainly with the transverse myelitis, it's just intimidating, because for me it feels like you have so much on your plate, thinking about your health, your future, making sure you get the proper care and attention, but just having a good working relationship with the physician, because the last thing you would want to do is like burn some kind of bridges with that physician. So I definitely like that sandwich approach and would use that in the future.
Yeah, and if everyone wants to practice, you can always practice on, a significant other or your children or something, or your parents, and see how it works. It's amazing. Before giving feedback in any situation, it's always useful to remember what's the goal of the feedback. So sometimes you're already leaving and you're giving feedback so they'll be different with the next person. That is rarely to sometimes effective at changing practice patterns. If people are already gone and in their anger or frustration, they're saying, well, I'm leaving and let me tell you why, you're really not going to influence dramatic change. If, however, your goal is to change the practice pattern relative to you, and if you think about that before you give the feedback, it really changes the feedback, because you want to set people up for listening and for really hearing you. A couple other things to consider just strategically, and Kristen, I don't know if you've ever witnessed this, but time of day of the appointment can sometimes make a difference. And Kristen, have you ever experienced, or can you think of even subtle ways that it's been different, seeing somebody in the first appointment of the day, the middle of the day, the last appointment of the day? Has that ever been a pattern you've witnessed?
For me personally, no. I mean, for the most part, I've been fortunate to have really good relationships with my physicians when I've seen them, and the time of day has varied for all of them, and I haven't seen really any difference for myself.
Yeah, so one of the things that comes up, and it's worth, if you're ever in a situation, if anyone's ever in a situation where they feel like they're not getting enough time for the complexity of issues, it is fair to ask the clinician to say, listen, I'm anxious about this. I feel like I'm not making the ground I want to get. I would like, and I know your time is valuable, and I know there are a lot of people to see. I have been told in the past that sometimes it's easier to spend a little more time on something if I were your first or last patient of the day. And ask, do you advise, is there any, would you advise next time maybe I pick your last spot of the day because I feel like there's more to go through? And some clinicians will very openly say, yes, absolutely. Next time you come be my last patient, and we can sit here longer and have a more detailed conversation. Another strategy in terms of time is to ask, and you always preface it with, I know there are a lot of people who need to see you. You're very busy. I really appreciate your time. Based on what we were able to get through today, I feel like I would benefit from at least one time booking a longer appointment. Is it okay the next time for me to book 2 spots on your appointment template versus 1, so we can have a little more time, because I really want to hear more of your thoughts about a variety of things. Is that possible? That's another strategy. And then a third strategy is to say, listen, I know we're only able to get through the number 1 on my priority list. Is it okay to book multiple follow-ups over the next few months and then space them out versus not seeing you again for 3 to 6 months? So those are multiple options to try and get more time with the clinicians. And one of the things embedded in each of those and should be verbalized in each of those is the plain fact, the reason you're doing it is you want the help. You want the insight, and you want them to take, I wouldn't say this, but what you want is them to take a breath and think about you, and to think about the challenges, and to think about what they can offer to lessen some of those challenges. And if the clinicians have their mind on the computer, their mind on billing, or the fact that things are already an hour behind, or whatever the case may be, it's harder for them to do what they want to do and what they were trained to do, which is to think. I'm not a surgeon. I'm not going in to surgically repair a spinal cord. I'm a medical doctor who the only way I'm of benefit to you is if I use my head. And that is directly related to the time we spend. And so you definitely want to engage people and get them to use that time. And so, Kristen, to your point, you said, if you weren't able to enact the changes in behavior that were important to you, you'd seek care elsewhere. It's a very legit, at some point, that is what people have to do. If they cannot effectively change behavior to a way that's meaningful, then they have to consider seeking care elsewhere.
Mm-hmm.
And for some of our listeners, that becomes a challenge based on geography and limited access to specialists. And so one of the things that comes up is finding any practitioner locally who's going to be your quarterback, and then if you have to travel to a specialty center but then do the follow-up with your primary and enact plans, that is an option. finding the person who's willing to invest time thinking and doing is more important than whether or not they were formally trained in transverse myelitis especially. And so, Kristen, if you had to rate what the quality was amongst all your practitioners that you think impacts your satisfaction with them the most, what are the things that you're looking for the most?
The qualities of my physician?
Yeah, from just the the qualities, whether it's they successfully handle my problems, accessibility, time. What is it that would be your priority? The artificial way this was asked in movies all the time is, would you rather have a insightful, listening, engaged clinician who is only marginally successful at alleviating issues, or a cold, completely uninterested clinician, but they had the answer to your issues? That's the artificial scenario that gets set up, but it gives you a sense of kind of what is it that we're all looking for.
Yeah, for me, it's my ability to get a hold of the physician.
So the accessibility.
Hi, Kristen. I think we're having a little trouble hearing you. I don't know if you can. I don't know.
Did we lose
yeah,
you,
let's just
Kristen?
give her a minute, and maybe we can talk about some other questions we've gotten, if you don't mind.
What have you gotten? Yeah, absolutely.
Yeah. So one of the questions we just got is about having a new care provider. So if you have your old history, how would you go about presenting, I guess, your history to a new care provider?
Yeah, that's a great question. So in a new patient visit, especially if you've had a long history around the diagnosis and subsequent management, it can be difficult to efficiently go through things. Bringing a written history can be helpful. The trick is knowing what to put in that up front. And so the way I encourage people to think about it is you want to have the written history and the Cliff Notes version. Some clinicians prefer the full version, some prefer the Cliff Notes. And having it written out is extremely helpful. Now, in the Cliff Notes version, part of it is trying to read your clinician's mind in terms of what they're looking for, which is very hard to do. But in general, what they're looking for is when a diagnosis occurred, what testing was done, what treatments were given, even back at the beginning, and then milestones over time, if we're talking about years, of recovery or issues. So if we're talking about walking, it would say when I was hospitalized I was unable to walk. By such and such point in time I was using a walker or a cane, and then I was walking with an orthotic, whatever the case may be. And putting it out in that context can be very helpful for efficiently going through things. In terms of the symptomatic side, anything you are seeking ongoing care for, it is useful to just have a list of what's been tried, did it work or not, and if not, why was it discontinued? So for example, if we'll use pain again as an example, if neuropathic pain has been an ongoing issue and you're transitioning to a new clinician, it is extremely helpful to list what medicines or interventions have been tried to treat the pain, when they were tried, the maximum dose used, and why the medicine was discontinued. Did it not work, or were there side effects, or was your insurance not going to pay for it anymore? So just a table that summarizes those things. is an extremely efficient way, and your clinician will love you to be able to go, okay, so you tried these 3 and they didn't work, but this one you stopped for side effects, and this one you only got up to a half dose. We can very efficiently move through, and you can use that for pain, you can use it for bladder, any of those ongoing issues. That summary of the diagnosis and that summary of ongoing care is, if that's written down, is extremely helpful. And when you first sit down with the clinician, the new clinician, you can say, I'm happy to walk you through my history, my concerns. I have it written down in case you want it, is very helpful. And then when you go to that visit, having in reserve, tucked away in your bag, any documents that may be needed. So in general, one of the top things that comes up in our clinic is we want to see actual MRIs, not just reports. So I encourage everybody to keep copies of their MRIs on CD for any new clinicians who may want them, just in case it comes up. A list of all of your current clinicians with fax numbers and addresses in case they want to send notes for communication. So come prepared to hand all of that, but start by asking, I'm happy to walk you through my history. I have it written. Tell me what's best for you, and going through it. But you also need to come with that priority list. And in a new patient appointment, it can take time to go through both of those things. So you definitely want to know of any active issues, what's your top priority to get addressed in that visit.
Thank you so much. That was really helpful. Oh, Kristen, can you hear us? Okay.
Yeah, I can hear you now.
Great. Did you have anything to add? The question was about providing like a history to a new care provider if you switch. Dr. Greenberg covered a lot, but I wasn't sure if you wanted to add anything.
No, I don't. I think Dr. Greenberg covered everything that I would have had in mind. Again, just going back to having your list of things in your pocket to hand off to any physician if they needed it. So.
That's great, thank you. So we have another question from the community, if you would like to share your thoughts. So the question was if there was any clinical or current information regarding transverse myelitis that practitioners can access or the patient can obtain, and how would you go about sharing this information with your doctor? And just as something from the Transverse Myelitis Association, we do have a resource library on our website, myelitis.org, that has a lot of medical and clinical information that we recommend sharing with doctors, but I'd like to hear your thoughts on that.
I can jump in.
Yeah, please, Kristen. Yeah.
If you want. So typically, what I found in my appointments that are not with my neurologist, if they're not familiar with transverse myelitis, is I give them a little background, and then I either get one of two reactions from them. One is they want to know more, and they ask more probing questions about it and where they can learn more about this particular disease, and normally I just direct them to the TMA website and to any of the TMA podcasts, like M101 podcast that was done a few years back, that might give them some more information. And then I have other doctors that may already know some about it, and they either will or won't ask for information. But for me personally, as a patient, I just direct the physicians to the TMA website. And I'm not sure what else there is out there that you, Dr. Greenberg, might suggest to pass along.
It looks like Dr. Greenberg might be having some
Oh,
audio
I'm
difficulties.
sorry. I didn't unmute myself. Sorry. I didn't want there to be background noise. So I was saying that the TMA website is actually a great place, both for patients and clinicians to go to, because it's synthesized and reviewed material. Kristen, have you ever had a situation where you either are attempting to or providing information to a clinician and it's a awkward exchange, for lack of a better term, meaning either they have a look or a comment and it feels as though they're not appreciating getting educational materials from their patient? Because I've heard this scenario described to me by some families.
Yeah, I've only had this experience once where I was trying to give a little more background on TM, because it's so hard as a patient to know how much the physician that you're talking with that isn't your neurologist does and doesn't know, because it's so rare. So I kind of started off tentative with giving like a little overview about TM, and then I kind of based their reaction on, okay, I can delve in a little more. Always being a little skeptical about whether or not they know as much as they might be leading on. So in the one experience that I did have, even though at the end of the appointment I wasn't convinced that the physician truly understood how TM affects me personally, I made sure to follow up, as you had mentioned, Dr. Greenberg, before, having that one physician that kind of is the overseer, or your kind of go-to or primary. I made sure that I got in contact with that particular physician, who for me tends to be my neurologist, to fill them in on what that particular medical appointment was about and what that doctor was recommending, since I didn't want it to any outcome from that appointment and what that physician was directing me to do. I just felt it was more important for my neurologist to be involved in that. So yeah, it's kind of a tricky situation that I found, kind of more so for some of your newer physicians, the first time you see them, figuring out how much they know and how much to provide them without kind of making, I don't want to say making them upset, but without stepping on their toes, I guess.
Yeah, and I think what you're picking up on, Kristen, is it goes back to ego, and I don't mean this in a harsh way. I mean it in a very human way, whether it's admitted or not. When it comes to the medical side of things, physicians like to feel as though they are in command of situations. Some of the hardest words for physicians to say are the words "I don't know." And in theory, what we're supposed to say is, "I don't know, but I will find out." That's what our job technically is. But that isn't always the case. And so I think if you're trying to lead your clinician to access resources, there are lots of ways to do it. So one is exactly how you did, Kristen, in terms of directly having the conversation at some point, using a quarterback as well. The other way is to leverage the TMA as an asset, and the way I do it is the TMA keeps listings and a map of clinicians that are interested in the care of patients with these rare autoimmune disorders. And sometimes I use that as the caveat of saying, listen, I'm a member of this patient advocacy organization, the Transverse Myelitis Association. They've got this really great website. It's got a patient portal. It's got stuff for clinicians. And they're asking us about clinicians we have in the community, who we like, who we're engaged with. And you've been great, and I've always valued our relationship, and I've appreciate you taking the time to talk to me. I'm not sure if you'd ever be interested in being listed on their site, but you should check it out. get clinicians to the site in a variety of ways. The other option is to say, hey, I've been listening to these podcasts around rare diseases, and there are several clinicians in the country who make themselves available to other doctors with questions. We've been trying to deal with my spasticity, and I appreciate everything you've done. They were talking about possibly some different approaches, and they've said if you reach out through the TMA or whatever, they're happy to help out. Would you mind vetting them to see if there are any approaches that you think would be useful? And so notice the twist to the language I'm putting in. You're not asking them to get a consult from Dr. Greenberg. You're asking them to be your agent to decide Dr. Greenberg's full of crap, or, hey, I like that idea, let's give it a try. And that is, again, a disarming way to get your clinicians to engage, because you're putting your trust and your faith in them. They're the ones that know you. It's not that you're putting your trust or faith in me, but you're trying to get them to pair up with me or Carlos Pardo or Alan DeSena or any of the specialists around the country who do this. And it's about how do you get them to take that first leap. So the more I find that people can put it into the context of valuing that relationship, the more often clinicians will follow through with accessing the information. And I will say that for the TMA, we ask clinicians their permission before posting them. So you can tell your clinicians they would never post without your permission. I'd love for you to reach out, because whenever a clinician reaches out, we also, besides making sure they're allowed, we make sure they're equipped with all of our resources.
Okay, well, thank you both so much. We're just about out of time. I just wanted to give a reminder to all of our listeners that this podcast was recorded and will be posted on the TMA website. So thank you both so much. I think this was really great and gave us a lot of information.
Thanks so much.
Thank you very much for having us.